Imagine feeling like your body is permanently structurally altered, right? Like something has fundamentally changed.
Right.
But then, when a doctor actually measures it, absolutely nothing has changed.
Yeah, it's a completely wild concept.
It really is. So, welcome to the deep dive. Today we are exploring a really taboo, but honestly incredibly common world of women's pelvic health.
Taboo is definitely the right word for it, unfortunately.
Right. And we're trying to answer a question for you today that sounds, well, almost impossible. Like, can a complete loss of physical sensation actually trip your brain into feeling quote-unquote loose?
Which is a question that, frankly, completely upends how we typically view the pelvic floor. I mean, society, and honestly a lot of the medical community too, tends to treat women's pelvic health as this purely mechanical issue.
Like plumbing.
Yes, exactly. Like plumbing or carpentry, like, oh, a pipe is loose, let's tighten the pipe. But, when you actually dive into the neurology and the tissue science, it reveals a reality that is just, well, it's far more complex and surprising than just structural damage.
And that is exactly our mission for this deep dive. So we are pulling from a massive stack of clinical literature for you today.
I really are.
Yeah, we've got the landmark developed Senate study from the PNC medical databases. We're looking at major clinical guidelines and some incredibly detailed StatPearls data on nerve entrapment and genitourinary syndromes.
All to figure out if reduced sensation is, like, actively being mistaken for vaginal laxity.
Exactly. Because if it is, that changes the paradigm for millions of women.
Oh, yes, absolutely.
So many women experience this feeling of looseness, whether that's postpartum or heading into menopause, and they just suffer in silence.
Yeah, they assume their bodies are just permanently stretched out and broken.
Right. Okay, let's unpack this. Because to understand if sensation is masquerading as laxity, we kind of have to look at what the clinical data actually says about physical structural looseness.
Right, which takes us directly to that developed study you mentioned. It is just a brilliant piece of clinical literature to start with.
I was reading through the methodology, and it's actually pretty straightforward, right? But very revealing.
Definitely. It was designed specifically to compare what a woman subjectively feels against what is objectively physically present in her anatomy.
So they brought in 95 sexually active women, average age around 54, I think.
Yeah, 54.
And first, they had these patients fill out this thing called the Vaginal Laxity Questionnaire, the VLQ.
Which is basically a 7-point scale.
Right, where the women simply rate their own perception of their anatomy, like going all the way from very loose to very tight.
So that captures the purely subjective, sensory experience.
Yeah.
But the crucial second step, the really important part, was pairing that questionnaire with a rigorous, objective physical exam.
The POPQ system, right?
Yes, the pelvic organ prolapse quantification system.
Okay, so what exactly are they measuring with the POPQ in this specific context?
Well, they are taking physical standardized measurements of the mid-vaginal caliber. So they're looking at the general hiatus, they're measuring the total vaginal length, and checking for any actual dropping of the pelvic organs.
That prolapse.
Right. They are quite literally taking a tape measure to the physical dimensions of the space.
Okay, so you have the patient's subjective feeling on one side of the desk and the cold, hard medical tape measure on the other.
Exactly. And what's fascinating here is the conclusion they reached when they compared those two data sets.
It's so wild.
There was no significant correlation between a woman's VLQ score, like how loose she felt, and her actual physical POPQ measurements. None whatsoever.
Wait, okay, let me make sure I'm following this because it feels entirely counterintuitive to me.
It does, right?
It's like having a favorite sweater, and it feels completely stretched out and baggy when you wear it.
Yeah.
But then when you put a measuring tape to the actual fabric, it hasn't changed size at all. How is that functionally possible when you think about the physical reality of, say, a vaginal childbirth?
Right.
Isn't a baby, physically stretching that tissue? How could the tape measure stay the same?
That sweater metaphor is super common, but it actually has a fundamental flaw,
Oh, really?
Yeah, because it assumes the pelvis is an inanimate object.
Ah.
The vagina isn't a static piece of fabric. It's a living, dynamic neuromuscular structure. So, yes, childbirth stretches the tissue immensely in the moment.
Obviously.
Obviously. But the lack of correlation in the developed study suggests that chronic, long-term looseness isn't this persistent structural gaping.
Okay.
And to really answer your question about how this is possible, we have to look at the secondary data from that exact same developed study, the partner data.
Oh my gosh, yes. That part of the research was fascinating
It's incredible.
because they actually asked the women if their sexual partners had ever commented on any laxity.
Right, and you would assume, logically, that if there was a major permanent structural widening,
The partners would be the first to notice the mechanical change.
exactly, they would feel a difference in the space. So what did the data actually show about the partner's perceptions?
It showed that only 28% of the partners ever commented on it at all.
Just 28%.
Yeah.
And of that group who brought it up, what was their actual feedback?
This is the mind-blowing part to me. The vast majority of them, 21% of the total, they said the tissue felt tight.
Tight, not loose.
Right. Only 7% actually said it felt loose.
It's crazy.
So you have a situation where the women are reporting feeling incredibly loose on this questionnaire.
Yeah.
The clinical tape measure shows literally zero structural correlation to that feeling.
Right.
And the majority of partners who notice anything are actually feeling tightness.
Exactly. So if we zoom out and connect this to the bigger picture, it proves that vaginal laxity is largely a subjective sensory experience. It's not a purely structural mechanical one.
Yeah.
The physical space hasn't necessarily widened at all. Instead, the feeling within that space has fundamentally changed.
Okay, so if the space hasn't actually widened, why is the brain screaming loose? Like, what is happening in the body's wiring to cause that massive disconnect?
Right. To understand that, we have to transition away from the structural carpentry of the pelvis, right? We have to look at the electrical grid.
The nervous system.
Exactly. Specifically, we need to talk about the pudendal nerve.
I saw the neurological data on this in the StatPro's research, but can you walk us through the anatomy a bit?
Sure.
Like, where exactly is the pudendal nerve, and why is it so critical to this specific sensation of looseness?
So the pudendal nerve is basically the primary data cable for the pelvic floor. It originates deep in the pelvis, branching off from the S2, S3, and S4 nerve roots.
In the sacral plexus, right, at the base of the spine.
Yep, exactly. And from there, it travels down through the pelvis and has to pass through this very tight anatomical bottleneck called the Alcott canal.
Okay.
And its primary job is to provide sensory feedback for the perineum and the external genitalia. It basically tells the brain what is happening down there.
But because of that specific pathway, passing through those tight, bony canals, it sounds incredibly vulnerable to physical trauma.
Oh, it's highly vulnerable. The most common mechanism of injury is mechanical stretching.
Like during a vaginal delivery.
Exactly, especially a prolonged pushing phase or, say, a forceps delivery. The pudendal nerve can be stretched significantly beyond its normal anatomical limit.
Ouch.
Yeah, but importantly, it's not just limited to obstetrics.
Right, I read that.
The clinical literature highlights that excessive cycling or repetitive microtrauma from certain high-impact sports can also compress or damage this exact same nerve.
So what physically happens to the nerve when it gets stretched like a rubber band or, compressed by a bicycle seat for hours?
It undergoes something called ischemia.
Which means a lack of blood flow, right?
Exactly. The physical pressure essentially cuts off the local blood supply to the nerve, and when a nerve is starved of blood, the myelin sheath, which is that protective, insulating coating wrapped around the nerve fibers.
Like the plastic on a wire.
Exactly like that. That insulation can become damaged. And when that's compromised, the nerve simply stops conducting electrical signals efficiently. It starts misfiring, or in a lot of cases, it just goes quiet.
Okay, so the data cable is damaged and the signal is dropping.
Right.
But how does a damaged, quiet nerve translate to a feeling of physical looseness? I mean, numbness is one thing, but looseness.
Well, this is the absolute crux of the matter. Imagine intimacy occurring, right? The brain is expecting a certain amount of sensory feedback.
Right.
It wants data about friction, pressure, contact. But if the pudendal nerve is damaged, it sends a muted signal, or maybe no signal at all.
Okay.
The brain, however, is this relentless meaning-making machine. It absolutely expects to feel contact. So when it doesn't receive that contact signal, it doesn't just logically say to itself, oh, my nerve must be experiencing ischemia.
Right. It just rationalizes the lack of data based on what it knows.
Precisely. The brain interprets the lack of friction as a physical lack of tissue. It interprets the neurological silence as empty space.
Wow. So it quite literally interprets numbness as looseness.
Yes. Reduced sensation is literally being mistaken for structural laxity.
That is just incredible.
The vaginal walls are still there. They are still making physical contact. But because the sensory cable is damaged and not firing properly, the brain falsely assumes the walls have moved further away.
That is such a wild translation error in the nervous system.
It really is. And to illustrate just how mechanical and positional this nerve compression can be, neurologists use something called the Nantes criteria to diagnose pudendal nerve entrapment syndrome, or PNES.
Oh, yeah, I read about the Nantes criteria in the notes. One of the primary diagnostic markers is completely positional, isn't it?
It is,
It's
yeah.
based entirely on whether the patient is sitting or standing.
That's right. For a patient with pudendal nerve entrapment, their pain or their numbness typically gets significantly worse when they sit down on a flat surface.
Okay.
But it is almost immediately relieved when they stand up, or, interestingly, if they sit on a toilet seat.
Because of the pressure on the pelvis, like the toilet seat distributes it differently.
Exactly. When you sit on a flat surface, your body weight pushes against the ischial tuberosities, your sit bones.
Right.
And that puts sheer mechanical pressure on the ligaments surrounding the Alcott canal we talked about. You are literally squeezing the pudendal nerve.
Oh, wow.
When you stand up or sit on an open seat, you decompress the area. So it perfectly illustrates how physical pressure on the nerve dictates the sensory experience in the pelvis.
It isn't about the pelvic floor muscle being permanently stretched out at all.
No, it's about the nerve being physically squeezed in a tight anatomical space.
Okay, so we have the illusion of the stretched sweater, right?
Yeah.
And we have the translation error of the compressed pudendal nerve.
Right.
But the clinical literature also makes it very clear that it's not exclusively a nerve wiring issue.
Yeah, but it's not.
The actual physical texture of the tissue itself plays a massive role in whether the brain perceives tightness or laxity.
Yes, absolutely. And this brings us to the concept of tissue compliance. We really can't talk about the electrical wiring without talking about the actual physical environment those nerves are living in.
Which naturally leads us to GSM, right?
Yeah.
Genitourinary syndrome of menopause.
Yes.
I think we all kind of know about the standard symptoms as estrogen drops during perimenopause and menopause.
Right, the hot flashes and all that.
Yeah. And locally, we know about vaginal atrophy, the loss of superficial epithelial cells, the drop in collagen. But what's fascinating is how the brain misinterprets that exact physical change.
Because as estrogen drops, the pelvic floor loses its natural hydration and lubrication. The whole tissue dynamic changes entirely.
The analogy I kept thinking of while reading through this section of the guidelines, it's like trying to turn a smooth metal doorknob.
Oh.
If your hands are incredibly dry, like winter dry, your skin just slides right over the metal. You can't get a grip at all. There's zero friction.
Right.
But if your hands are properly moisturized, or even just have a tiny bit of natural tackiness to them, you grip the knob easily.
That's a great way to put it.
So when the vaginal walls lose that hydration and plumpness due to low estrogen, the natural friction just disappears.
That is a brilliant way to visualize it. And again, think about the brain as that meaning-making machine. How does it interpret that sudden lack of physical friction?
It reads it as loose.
Exactly. It says, I don't feel the drag, I don't feel the friction, therefore the space around me must have gotten wider.
Even though it hasn't.
Right. When in reality, the space is exactly the same, or frankly, perhaps even narrower due to the tissue shrinkage that happens with atrophy.
Wow.
But because the surface texture has changed, the sensory feedback is entirely different.
Here's where it gets really interesting, though, because it's not just a menopause or an estrogen issue.
No.
The clinical data also pointed to Ehlers-Danlos syndrome, EDS, and generalized hypermobility.
Yes. Connective tissue disorders. This is such a critical layer to the puzzle, and it is so often overlooked in standard gynecology.
So with hypermobility, or EDS, the body produces faulty collagen.
Right. Essentially, yes.
So the tissue is inherently incredibly stretchy. For these patients, their quote-unquote laxity isn't necessarily about weak muscles or a lack of estrogen. It's about how their connective tissue yields to pressure. Is that right?
Yes. The clinical term is tissue compliance. Think about, imagine a trampoline that has lost its snappy return bounce.
Okay.
The springs are still there, the mat is perfectly intact, but when you jump on it, it yields way too far and takes too long to snap back.
Oh, I see.
So a patient with hypermobility might have excellent, really strong pelvic floor muscles, but because their connective tissue is so compliant, so stretchy, it just yields instantly to any pressure.
So they don't get that pushback sensation at all.
Exactly. Plus, hypermobility often comes with altered proprioception.
Which is what exactly?
It means the brain's internal map of where the body is in space is already slightly fuzzy. So when you combine highly compliant tissue with altered proprioception, the sensory feedback they get during intimacy feels exactly like profound laxity.
That makes so much sense.
It proves yet again that tightness isn't some simple binary measurement of muscle strength. It's an incredibly complex interplay of tissue resilience, hydration, and neurological mapping.
Well, this brings up a rather frustrating reality check about how this is actually treated out in the wild.
Oh, definitely.
Because if a woman feels this looseness and she goes online and Googles vaginal laxity, she isn't met with, like, nuanced explanations of the pudendal nerve or tissue compliance.
Not at all.
She's immediately bombarded with marketing for very expensive non-surgical vaginal rejuvenation.
The massive boom in energy devices.
Yeah. We're talking about fractional CO2 lasers and radiofrequency treatments like Vivev.
Right.
The marketing brochures for these clinics, they promise to tighten the vagina by delivering heat into the tissue to stimulate new collagen production.
Yep, that's the claim.
But after everything we just discussed, I have to ask directly, if the root cause of a woman's laxity is actually a crushed pudendal nerve or a systemic drop in estrogen, are these expensive laser clinics just selling snake oil?
Well, this raises an incredibly important question about the intersection of commerce and evidence-based medicine, right?
Yeah.
Are they purely snake oil? Not entirely. But are they the magic structural cure they claim to be? Absolutely not.
Okay, let's break down the actual mechanism then. Why wouldn't a laser work for nerve-induced laxity?
It basically comes down to basic anatomy and the depth of penetration. Energy devices are designed to heat the very superficial layers of the tissue,
Like just the surface.
usually just the top millimeter or two of the mucosa.
Yeah.
This mild thermal injury triggers the body's wound healing cascade, which, it can stimulate some local collagen and increase blood flow.
Which might actually help with the doorknob friction issue we talked about.
Correct. For a patient suffering strictly from GSM, that menopausal dryness and lack of superficial friction, a laser treatment might temporarily improve the tissue texture.
Okay.
It might add a bit of that friction back, which the brain happily interprets as tightness.
Oh.
But a surface-level laser cannot reach the pudendal nerve. That nerve is buried deep in the pelvic floor, protected behind thick ligaments and fascia.
Right, it's not just sitting on the surface.
Exactly. You could fire lasers at the mucosal strip all day long, and you wouldn't come close to decompressing an entrapped nerve in the Alcott Canal.
Wow.
Furthermore, lasers cannot reattach a levator antemuscle that was avulsed,
Look, Volse.
meaning literally torn completely away from the pubic bone during a traumatic childbirth. They cannot reverse a true structural pelvic organ prolapse either.
That makes a lot of sense, and I actually noticed the clinical guidelines are quite cautious about these devices.
Very cautious. The UK's NICE guidance, the National Institute for Health and Care Excellence, which is really a gold standard for clinical pathways, they clearly state that the long-term evidence for transvaginal laser therapy is currently inadequate.
Oh, wow. Inadequate.
Yes. They actually recommend that its use should remain limited strictly to research settings.
That is a massive caveat that you definitely do not see on the promotional Instagram ads for these clinics.
You certainly do not.
So if a woman walks into a med spa saying, I feel loose, and they just, point a laser at her without investigating why she feels loose, they're treating a complex neurological symptom completely blindly.
Which is why the proper clinical pathway must always start with a differential diagnosis, not a shiny new device.
Okay, so let's lay out the right path then. If lasers aren't the magic bullet, what does the clinical literature say actually works for these patients?
The consensus points to a very clear hierarchy of treatment. The absolute first line is pelvic floor physical therapy.
Okay.
And I don't mean just telling a patient to do Kegels while stopped at a traffic light.
Right.
I mean working hands-on with a specialized physical therapist who evaluates muscle coordination. They often use the Oxford grading system to measure the actual power and endurance of the contraction.
Because, as the data points out, a woman might be doing Kegels completely incorrectly, right? Or her pelvic floor muscles might actually be in a state of hypertonic spasm rather than being too weak.
Precisely. If the muscles are locked in a spasm, doing more Kegels will only make the compression on that pudendal nerve worse.
Oh, that makes sense. It would just squeeze it harder.
Exactly.
Yeah.
A physical therapist can actually help release that tension. Now, if the underlying issue is diagnosed as genitourinary syndrome of menopause, the first-line medical treatment is local topical vaginal estrogen to safely restore tissue thickness and hydration.
And what role does surgery actually play in all this?
Surgery, such as a traditional vaginoplasty, is generally reserved for actual, clinically measurable structural failures.
So when the tape measure actually does show a change,
Right. If the POPQ exam shows a true pelvic organ prolapse, or if an MRI confirms a severe muscular avulsion from childbirth, then a surgeon can physically reconstruct that anatomy.
Right.
But performing a structural surgery on a patient whose feeling of laxity is purely sensory, driven by a compressed nerve or hypermobility, will not solve their problem.
Wow.
It might even introduce new scar tissue that worsens the nerve entrapment.
Gosh. So what does this all mean for you? If you were listening to this right now and you have felt a loss of vaginal tone or a distinct change in sensation after having a baby or, as you navigate perimenopause, do not immediately assume your body is permanently stretched out.
Definitely not.
The simple binary X-ray machine doesn't work in this landscape. That feeling of looseness is highly likely to be a sensory translation error.
It really is.
It is your brain misinterpreting a compressed nerve or a loss of tissue hydration or a shift in connective tissue compliance.
The laxity illusion is a very real phenomenon, and the distress it causes women is entirely valid. But understanding the underlying biology, the nerves, the tissue, the brain, it empowers you to seek the right kind of care.
Right.
Care that actually targets the nervous system and tissue health, rather than just chasing a physical tightness that was probably never even lost in the first place.
It completely changes how we approach pelvic health.
Right.
I mean, it takes the blame off the physical structure and puts the focus on the neurological function.
It absolutely does. But before we wrap up today's deep dive, I do want to leave you with a final thought that builds on everything we've uncovered here.
Okay.
If we accept that vaginal laxity is largely a subjective, sensory perception-like, an interpretation actively made by the brain, we have to seriously wonder about the role of the mind itself in this equation.
Oh, wow. I see where you're going with this.
Think about the immense, deep-seated cultural anxieties women carry.
Yeah.
Anxieties about aging, about the perceived ruin of their postpartum bodies, about sexual performance, and living up to some impossible aesthetic ideal.
Right. If the brain is the ultimate organ interpreting these pelvic signals,
Huh.
could our pervasive societal anxieties actually be rewiring how our brains interpret sensation?
Gosh.
Are some women feeling structurally loose simply because society continually tells women that their bodies are diminished and flawed after childbirth and aging?
Wow. That is a heavy, profoundly necessary question to ask. I mean, are we experiencing a genuine physical symptom, or are we literally feeling the neurological weight of a cultural expectation?
Exactly.
We started this deep dive by talking about how comforting a simple medical diagnosis can be. But the truth is, our structural anatomy, our electrical nerve wiring, and our psychology are woven together in a way that is brilliantly complex.
Beautifully said.
Well, thank you for joining us on this deep dive into the clinical literature for you today. Keep questioning the answers you're given and keep exploring the world around you.